Good afternoon and welcome to our May Grand Rounds webinar. I'm Dr. Patrice Nicholas. I'm Director of the Center for Climate Change, Climate Justice and Health, and we're delighted to co-host these webinars with the MGH Center for the Environment and Health with the leadership of Dr. Winnie Armand. And Dr. Suellen Brakey also joins us, Associate Director of our MGH Institute Climate Change Center. Today, the webinar will focus on traffic-related air pollution, followed by effects of nuclear weapons and avenues, for clinician advocacy. Next slide. We also want to share the upcoming Grand Rounds webinars. On Wednesday, June 15th, the topic will be sustainability in medicine, improving value and reducing the environmental footprint of healthcare delivery, presented by Dr. Cassandra Thiel from the Grossman School of Medicine. And in July, the topic will be climate change and disasters, what the healthcare system needs to do differently, presented by Dr. Paul Bittinger, Chief Preparedness and Continuity Officer at Mass General Hospital, and the Prestipino Endowed Chair in Emergency Medicine. Next slide. And now I'll hand over to our colleague, Dr. Winnie Armand, to introduce today's speakers. Thank you.
Good afternoon. Welcome, everybody. Thank you for joining us. I want to just remind you that this will be recorded and you will receive an email a few days later with the recording link. Please also note that you can ask questions and answers. There is a Q&A button at the bottom of the Zoom, so feel free to put your questions throughout the talk. What we'd like to do today is divide this session into really two talks. So we'll focus with our first speaker, the first half hour, and then do questions and answers, and then move on to our second speaker and do questions and answers in two segments. So I have the distinct pleasure to introduce to you our first speaker, Dr. Carlos Camargo. Dr. Carlos Camargo is a professor of emergency medicine and also a professor in epidemiology at Harvard University. He has the Conn Chair in Emergency Medicine at Mass General Hospital and founded and leads the Emergency Medicine Network, which is an international research collaboration with over 240 hospitals, which focus on respiratory and allergy emergencies, as well as health services, research in emergency care, and adverse social determinants of health. Dr. Camargo also works on the role of nutrition in respiratory and allergy disorders, both in large cohort studies as well as randomized controlled trials, and studies effects of vitamin D are a major focus. He is the past president of the American College of Epidemiology and has worked on several US guidelines, including those on diet, asthma, and food allergy, and is the author of well over 1,000 publications. We are so grateful, and it is my pleasure to pass the mic over to Dr. Camargo.
Oh, thank you so much. And I will now share my screen. And we'll get started. So this first presentation of our two-part session is going to focus on some research that I've been doing, and I'll transition a little bit to advocacy, and then you'll hear from our next speaker who's going to be really pushing hard on clinicians as advocates. But the topics are unrelated in their content of air pollution versus nuclear war. So let's get started on traffic-related air pollution. First off, to start, no disclosures. And here's an overview of the presentation. I'll just very briefly introduce the network that is behind the original research I'll present to you. I'll then very briefly introduce traffic-related air pollution, or TRAP, childhood asthma, and I'll make a distinction here, which I think is very important. It's one of the take-homes, that asthma can be looked at as an outcome as new asthma or incident asthma, or you can look at among people with asthma, do they have exacerbations? And they don't necessarily have the same association with risk factors. So this is an important distinction that is often lost on, when I read about asthma and traffic and air pollution, et cetera. So I'll then go into TRAP and how it relates to incident or new asthma, and then TRAP and asthma exacerbations, and wrap up. So just briefly, the Emergency Medicine Network is behind all this, founded in 1996, based at Mass General. We look at public health objectives. We advance them through projects in emergency care. We have most of our funding from the NIH and lots of publications. Again, a major focus on asthma and allergy. Now, air pollution is something that this group knows a lot about, a lot more than me probably. But there are multiple sources, and I'm going to just focus on traffic-related air pollution to the extent that I can, which again is just one of many sources of pollution. By focusing on only one, that does raise concerns perhaps about how you're not fully capturing the exposure to the child, and that is sort of a problem with this line of research. If you only focus on traffic and there's other things going on, you're not going to see the big picture. So that's an important caveat. But distance to highways, to big roads, is clearly related to all kinds of specific air pollutants. This is a very classic slide showing distance to the highway, either upwind or downwind. And you can see that if you're within 100 meters, you have downwind, you have a much higher risk of being exposed to particle mass, black carbon, and other sort of traffic-related pollutants. And this is how the idea of residential distance to a major road became an exposure. It's something that's not that hard to get. If you geocode where people live, you know where the roads are, and then you can estimate sort of approximately how much of air pollutants they get. A much better way, of course, is to measure the air pollutants, but of course we don't have monitors in every house, and we don't have monitors on every block. So sometimes these proxies can serve us well, although they can't dissect out the specific air pollutants. So in terms of TRAP, it's usually reported as a distance, and it can vary across in the literature. Sometimes the focus is on primary roads, which are the state or US numbered highways. Other times, and I think it's better, is to look at major roads. And so this includes both primary and secondary. And the secondary include all the county highways. So in theory, you're getting all highways. You could live right next to a very busy county road, with a lot of pollution, and you would not be captured if you looked at primary roads only. Again, as I mentioned, there are many more direct measures of traffic-related air pollution, nitrous dioxide, et cetera. And that would be preferable, except it's hard to get that data at the individual level in huge cohort studies. So again, we use this proxy of distance from major roads in the meantime. In terms of asthma, it's a chronic lung disease, and it's got these three characteristics: airway narrowing, that is reversible, either spontaneously or with treatment. And the treatment would be like an albuterol inhaler. And again, many clinicians on the call, and you know what asthma is. But another component of asthma that's harder to see at the bedside, but is probably critical to its etiology, is the inflammation that's in the airway. There's also hyper-responsiveness to a variety of stimuli. We know that when people have allergies, when you expose them to like a cat dander or mold, that their airways become twitchy and they close, and that's the airway narrowing that causes an asthma exacerbation. Another potential trigger would be air pollution. So that's why this area has been a focus of interest for many years. Millions of Americans have asthma. The definition is not always applied very well. So asthma is sort of a heterogeneous group of diseases. And today, in the last 10, 20 years, there's been more and more interest in sort of asthma phenotypes, specific types of asthma. But that requires a lot of clinical data, laboratory data, to sort of split people into a more allergic asthma versus a more bronchospastic, obesity-related asthma. And so again, most studies sort of deal with asthma as a big clump. So you have an exposure that's a proxy, you have a disease that's kind of a heterogeneous mix. You can see how it would be possible to not see much, partly because of the sort of the lack of granularity of the exposure and the outcome. We do know, though, that millions have asthma, and they account for a lot of exacerbations. I've listed there 12 million exacerbations, 2 million ED visits, et cetera. There also are major risk factors that have been identified. Some of them are fixed, like your age. We know that asthma usually starts in early life. Probably 90% of all asthma is started during childhood. We also know that there's gender differences, with boys predominating early in life. During the adolescence years, girls tend to have more new asthma. During the reproductive years, again, women tend to have more asthma than men. And then after menopause, it tends to equal out again. So it's arguing that there's probably a strong role of sex hormones in this disease. Allergy, or atopy, is also very important. A major risk factor is parental history of asthma. And many of the birth cohorts that have been started to study asthma actually require that parent have asthma so they can have enough cases accrue to do their research. Not all, but many birth cohorts do have that requirement. Parental smoking is also important as a risk factor. And another risk factor, which I think has been overlooked to some extent, is severe bronchiolitis. Now, this is an infant respiratory infection that is actually associated with a much higher risk of developing asthma, and has been a particular focus of mine for the last 10, 15 years. And that's partly what I'll be presenting to you today. Now, all this together has come up with this, with sort of a summary that's called the hygiene hypothesis. And it kind of fits, it kind of doesn't. It's very popular, everyone knows about it. And I'll just show you this next slide about a child who is, if the hygiene hypothesis is true, this child is unlikely to get asthma. Now this hygiene hypothesis is, again, not entirely solid. I think there's a lot of truth in it, but it doesn't capture the complexity, certainly, of all the different asthma types. And so we go back to those fundamentals, like what are the risk factors and how do they relate to the disease? And a big question for many years has been, does air pollution cause asthma? And there is controversy in this. It's been the subject of many meta-analyses. I'll summarize the results shortly. But when you pool big cohorts together, you use the birth address only, and you look at specific air pollutants, you see this kind of an association where on the x-axis is age, on the y-axis is risk. And if you look specifically at NO2, you can see that by the age of 6 to sort of early adolescence, there is an association between a higher level of NO2 exposure and risk of developing this composite of asthma. And the same is true for PM2.5. So this is one of the strongest studies. Now, there are many others that don't show this association, but it's always unclear if it's because they're using sort of not as good exposures, the outcomes are too fuzzy, there aren't enough people. But again, this sort of tells us that there's something here and that we should take a look at it. So over the last 5-6 years, there's been many reviews and meta-analyses, and I've summarized them here for you. There's a paper in Allergy in 2015, and that concludes heterogeneous studies with mixed results. They do emphasize that there's a stronger association between TRAP and asthma in later childhood, which is like what you just saw in the previous slide. Another 2017 review, again, comments on heterogeneous studies with mixed results. But when they did their meta-analysis, they did see associations with black carbon, which was more stable and robust than that with NO2 or the particulate matter outcomes. But all of them seem to be associated. In a subsequent paper, though, by the same author, he really critiques the exposure and outcome assessment and includes that we really have to get past birth data. We need to have longitudinal data to look at this. We also need to do a better job of controlling for confounders, because people who live near traffic are probably different from people who live far from traffic. And what if it's those other factors that are responsible? And then I think most importantly, the author really emphasized, like, well, maybe there's effect modifiers. In other words, maybe there's an association between TRAP and asthma, but it's more true in this group than in that group. And that by lumping everything together, we're missing important signals. In a subsequent paper in 2018, there was also this call for, well, we should be focusing on asthma phenotypes, the different types of asthma. And there actually weren't enough articles to even do a meta-analysis. So they called for more research. And then more recently, just in the last months, there's a paper by Han in Environmental Research, which again found significant associations for NO2, PM2.5, and then in a new one is the benzene and TVOCs. And they also call for more research. So I want you all to appreciate that although there is definitely a signal between TRAP and incident asthma, more research is needed. Now, I say that in the context of a report that came out in 2020, where some of the leaders in the field all got together at, in this American Thoracic Society workshop. And, these people who study this topic concluded, as you can see, epidemiologic and toxicological evidence convincingly indicate a causal induction of new childhood asthma by long-term outdoor air pollution. And then they say that the data are a little less clear in adult onset asthma or chronic obstructive pulmonary disease, COPD, then more evidence is needed. This is written at the same time as those other meta-analyses that are saying, more research is needed. My take on this is that they're probably right. But the literature is not as crystal clear as it sounds in this conclusion. Because there's a lot of null studies and a lot of noise, and I understand why. So this was the context in which we at MNet started to look at this issue a couple of years ago. We have multiple cohorts that we could use here, but the ones that I'll highlight are the Mark 35 study, which is about 1,000 kids that we're following over time, who presented to the hospital with severe bronchiolitis as infants, and we're following them to see whether or not they develop asthma. About 30% do, and why do they develop asthma? So we have basic risk factor information, but we also have lots of omics data, genomics, microbiome, all kinds of stuff about them, metabolomics, proteomics. And we thought we should look at TRAP in this population, and if we find something, we can try to figure out, like, what are the mechanisms. The other group that I want to highlight is Mark 43, which is, you could think of as a control group. They're going through the same experience as the Mark 35, but these are healthy kids who were never hospitalized for bronchiolitis. And again, they're being followed to development of asthma. So these cohorts have about 1,600 total. They were enrolled around 3 months. As I told you before, the bronchiolitis group, a little more boys, but again, one of the things we're very happy about is that we have really good representation from non-white participants. So that allows us to look at some issues of race, ethnicity, and how it relates to asthma. The location of these kids is all over the country, and they're continuing to spread. And in terms of TRAP, these are the healthy kids, the black dots. They're coming from 5 different sites, and to which we've mapped the primary roads, but really our focus, our a priori primary exposure is major roads, which are all over the place and are really the major source of traffic-related air pollution exposure. So this is not published. We are just trying right now to wrap up the outcomes and run the analyses, but cohort participants are currently undergoing their 6-year assessment, which is what's going to yield the asthma status. And also we have them doing spirometry for pulmonary function. So in the meantime, we do have this age 3-year recurrent wheezing outcome, which is a big deal in childhood, lots of respiratory infections and problems of that sort. But it is not the same as childhood asthma. And the preliminary results in these 700 plus kids with really great characterization of who they are, where they are, et cetera, is that there is no significant association between proximity to major roads, either using the birth variable or the pooled variable over time of where they moved, because we have longitudinal data, and risk of age 3-year recurring wheezing. So clearly that's very disappointing. And so we wonder, is the trap exposure too crude? You know, we need to get specific NO2 and black carbon, all that kind of data. But these kids are still pretty young, and that kind of data does not yet exist to be applied to these kids. It will be soon, but not yet. Or is it that healthy children are less susceptible to trap? That some may develop asthma as a result, but others won't. So this is an unanswered question, to which I then respond with our bronchiolitis cohort. Now, bronchiolitis is a clinical syndrome also. It has multiple definitions, but at the bottom line is that it's an acute lower respiratory infection, it has inflammation, and it's caused by one or more respiratory viruses, typically RSV. There's different definitions of age, but most people around the world suggest that it should be diagnosed during infancy, so early in life. And in MARC 35, we enrolled 900 kids who were hospitalized for bronchiolitis and have been following them. So what is the association for them with TRAP? Well, important to know that bronchiolitis is the #1 cause of infant hospitalization at about over 130,000 cases per year. It's about 2 to 3% of all infants who are hospitalized for their bronchiolitis. And also, as I mentioned earlier, about 30% will develop asthma. So here's the map of this cohort, their location, the major roads, shown in the light orange. And here's a publication from last year where we actually looked at birth distance to major road and to primary road as a secondary exposure. And as I mentioned to you, when you look at primary road, you can see here there's like really no association. But when you look at major road, even using the birth resident location, a nice signal emerges where you have a much higher risk, 50% higher risk of developing recurrent wheeze compared to children who live more than 300 meters from a major road. When you then look over time at where children live and you sort of average their exposure over those first 3 years, you see an even stronger association. And so this is what we were hoping to see, that with better data, we would be able to see. And again, in a higher risk group, perhaps, some children who are somehow more vulnerable to traffic-related air pollution. We then have 5-year asthma data as well in this paper, and you can see here that, again, primary road, nothing, there's no signal. But when you look at major road, which includes all the kind of highways, there is a signal that children have higher risk of developing asthma if they live closer to major roads. So in the birth distance, the finding gets kind of attenuated, non-significant when you adjust for confounders. But in the pooled multi-measurement over time, over the first 3 years, there remains a finding that is significant. And remember here, this is a lot of children being exposed. So being at an increased risk has public health implications. So are there effect modifiers? Well, I'm suggesting one, which is the fact that some children had bronchiolitis, others didn't. Well, here's a study that came out just in the last few months that has 732 participants in a Paris cohort. They looked at early exposure to TRAP. They looked at 13-year asthma, which again might be a better signal according to all the other previous meta-analyses. And they specifically tested to see if the TRAP was worse among people of different sex, who had a parental history of allergy, who had a stressful life event early in childhood, or who had lower respiratory tract infection like bronchiolitis. And the results were shown here, that prenatal NO2 levels were not associated. Higher infancy was associated, but it was especially true among those who had these effect modifiers. And you can see that here. Among children who had a parental history of allergy, there was higher risk, but among those who didn't, there was nothing. Especially true if they had asthma, again, but if you didn't look at that factor, you found nothing. Also the stressful family event, and then of most interest to me in this presentation is if you had a lower respiratory tract infection, you had a much higher risk of getting asthma at age 13 years. So now I'll just transition very briefly to the advocacy part of the story, which is exacerbations. While incident asthma may be somewhat unclear, and I think the consensus of the experts is correct, but the evidence may not be as strong as we want. This evidence is very strong. We know that people with asthma, when they breathe air pollution, they're not going to do well. And that's been well established in terms of a variety of outcomes. And so, do we really need more studies showing that breathing air pollution is bad for people with asthma? I don't think so. But we probably need laboratory studies that focus on specific pollutants and specific subgroups, because this effect modification is probably relevant here too. But what's most pressing is the need for policy interventions to show that when you change the air pollution, it gets better. And I want to show you 2 slides and then close. And these 2 slides have already been published, but I have been struck by the number of people in the climate change, air pollution community who don't know about these studies, but they're so powerful. So this was in 1996 in the Atlanta Olympics, where the city decided that they were going to try an alternative transportation strategy during the Olympics to decrease downtown congestion and decrease pollution for the athletes. And they would measure the air quality and asthma events during this time. So, yes, the weekday morning traffic counts dropped. The meteorologic conditions did not change during the Olympics in Atlanta. The air quality, not surprisingly, improved. And the acute asthma care events decreased dramatically by 42% according to medicated claims, 44% on HMO data, 11% in 2 pediatric EDs, and 19% in hospitalizations. Non-asthma events did not materially change. And you can see that there's just nothing going on. You lower the traffic-related air pollution in Atlanta, less childhood asthma events, done. And this was published 20 years ago. This should be part of every effort to say, look, if we changed our policies, we could have an impact. This was actually repeated in the 2008 Beijing Olympics, where again, they looked at transportation and industrial emission restrictions to improve air quality. They found very high compliance with their interventions in China, not surprisingly. Traffic restriction in Beijing, this was done right before the Olympics. It yielded only a modest improvement in air quality and no change in asthma events, which is not as good as the Atlanta. But when you added the industrial restrictions, air quality improved, and during the Olympics, outpatient asthma visits at a Beijing hospital decreased by 46%. So these are the kind of policy experiments that have been done, are published, and are available to make the case that if we want to lower asthma exacerbations, this is something we could do. Now, it comes with significant economic costs and shock to the community, et cetera. But I think this part is clearly shown. So in summary, proximity to major roads and incident asthma, new asthma, no apparent association in our data is preliminary look, but we haven't yet really looked at asthma. But we do see increased risk of asthma in children with an underlying predisposition to airway problems. We're going to look at other effect modifiers. We're going to look at TRAP and other outcomes like allergic rhinitis, and then we're going to explore mechanisms among those who do develop asthma. And then the second point about the advocacy is that there is just abundant evidence that TRAP's related to exacerbation, including this very compelling evidence from the Olympics, which is, if it's new to you, I hope you find it as compelling as I did when I read it. Thank you. Dr. Armand, I think you're on, we can't hear you.
I see Sue Ellen is here. So Sue Ellen, I think, is going to field questions. Thank you so much, Dr. Camargo. That was amazingly interesting and fascinating. I will pass it to Sue Ellen.
Thanks, Winnie. And just logistically, oh, I've got a question. I'm not sure how long we want to do questions before the next speaker, but I have a, by the way, thank you. That was a fascinating talk. learn something new about the Olympics. And, you know, the whole time you're talking, I'm thinking about Chelsea and, you know, the air quality there and its impact. But we have a question. Can you comment on the Southern California children's study, which found decreased incidence of asthma with long-term decreases in both NO2 and ozone? Both of those are mostly traffic generated in Southern California.
Yeah, so the person is referring to a study published in the 2000s, which was really the first one that raised the possibility that it's not just asthma exacerbations, it may be causing asthma. And this is a very nice epidemiologic study which showed in Southern California with lots of pollution that there was an association between higher long-term exposure and risk of developing asthma. Now that was 20 years ago. There's also some more recent studies showing that it's harder today to show that than it was 20 years ago for a variety of reasons. But that is definitely a driver of this whole campaign to see whether or not air pollution causes asthma. And at the end of the day, I think we will find that it does. These specific pollutants for this long, in this age range, for this type of asthma are bad. And that was the first clue.
Great, thank you. Two questions related to COVID. One is, do you anticipate a large increase in pediatric asthma after COVID-19 infections, particularly since many children are experiencing serial COVID infections? And then I'll add on to that, any data on the effects of traffic decline during the COVID pandemic?
So the second part, traffic decline during COVID, fascinating idea. To my knowledge, I don't think people have looked at that yet, but it does present another possible natural experiment like the Atlanta Olympics and the Beijing Olympics. I think that's a great idea. In terms of COVID-19 and asthma exacerbations, paradoxically, by wearing masks and avoiding respiratory infections, we've seen one of the best years ever in terms of asthma control. And so asthma visits to emergency departments have declined, bronchiolitis, I mean, all of these kind of respiratory infection related problems decreased during COVID. Probably also because parents were reluctant to go to the hospital. I mean, they sort of hung on at home as long as possible. But really, if you wanted to control your asthma, one of the things you might want to do is wear a mask. That is one of the things that we now have pretty good evidence for. So in terms of COVID itself triggering asthma, there's a specific type of asthma that if you get COVID, you are going to probably have a worse outcome. But other types of asthma are not so clearly linked to badness with COVID-19. So I think at that, I'm going to have to stop and give our next speaker his time. So
Great. Thank you so much.
Thank you so much, Dr. Camargo. I really hope that your research can be implemented into real policies. And I think there's a lot of work that we need to do. And it's based on research like yours that we can do the work. So thank you.
Thank you.
I'm going to transition over to our next speaker. We're really fortunate to have with us Dr. Joe Hodgkin. Dr. Joe Hodgkin trained at the Brigham and Women's Hospital, and he recently joined Mass General in the Department of Medicine as a hospitalist. Clinically, his interests lie in addressing the wide range of patient needs in hospital medicine, especially in older patients and patients with substance use disorders. As a board member of Greater Boston Physicians for Social Responsibility and a member of its affiliate, International Physicians for the Prevention of Nuclear War, he is active in physician advocacy to address the public health threat of nuclear weapons. His work includes medical education, lobbying, and citizen diplomacy initiatives through IPPNW's network of physicians across the world. He's traveled to Russia as part of his work and has been featured in the Boston Globe. And I actually heard you, I think, on National Public Radio as well. So I'm going to turn over the mic and slides to Dr. Hodgkin. Thank you.
Great. Thank you so much, Dr. Armand. And also thank you, Dr. Camargo, for that great talk. So I'll go ahead and share my slides here. The topic of my talk here is the medical and humanitarian effect of nuclear weapons and avenues for clinician advocacy. I have no financial conflicts of interest. My nonprofit affiliations are as mentioned by Dr. Armand, and that's some of what I'll be talking about, although any opinions here are my own. And we know from the headlines here, so on February 24th of this year, Russian forces rolled into Ukraine, and we've seen in the resulting war a lot of very concerning war crimes and human rights violations, indiscriminate attacks on civilians and civilian infrastructure, including hospitals, evidence of execution-style killings of civilians, use of landmines and cluster munitions, and many other really horrific reports. And even when we talk about so-called conventional war without weapons of mass destruction, we know that the public health effects extend far beyond morbidity and mortality for combatants and targeted civilians. Much of this has to do with the destruction of civilian infrastructure, food, water, transportation, sanitation, leading to starvation, epidemic, and exacerbation of chronic disease. And we also see effects related to displacement, refugee status, landmines, sexual violence, psychiatric morbidity, and so on. Another important thing to mention here is the risk to nuclear reactors. So as we know, the Chernobyl exclusion zone is back in Ukrainian hands, but even more dangerous is the threat to active nuclear reactors. So this is some footage from the Zaporizhia nuclear plant, which is the largest nuclear reactor in Europe, which was seized by Russian forces in early March. And you can see some damage here to the walkway between one of the main reactors and a wastewater treatment facility. The next slide here. And we know that threats of the use of nuclear weapons have been exchanged several times here. And I don't have to read these quotes, but these are from the headlines. I'm going to move on to the health effects of nuclear weapons here. And so conventional weapons, we're talking about weapons where the energy being released is stored in chemical bonds between the electrons, whereas a nuclear weapon releases much more efficiently stored energy in the nucleus of an atom. So this was originally fission reactions with splitting atoms, and then in the 1950s, the more powerful fusion weapons were designed, also known as hydrogen or thermonuclear bombs. The yield of these weapons is measured in equivalent tons of TNT. So 1,000 tons is a kiloton, 1,000,000 tons is a megaton. The weapons dropped on Hiroshima and Nagasaki were on the order of tens of kilotons, and then the subsequent hydrogen bombs developed later in the Cold War were on the order of hundreds of kilotons, megatons, or even tens of megatons. There's been a lot of talk as well about these smaller so-called tactical nuclear weapons intended for battlefield use, which have never actually been used but are deployed in the forces of the nuclear armed states. And right now there are about 13,000 nuclear weapons in the world, down from a peak of 70,000 in the 1980s, 90% in the hands of US and Russia, 10% with the other 7 nuclear armed states, and about 2,700 strategic deployed. And when we look at the health effects of nuclear weapons, our sources of data are the large longitudinal cohort studies from Hiroshima and Nagasaki, evidence from nuclear accidents, including Chernobyl, the health effects of medical radiation, and then also modeling studies. I'll be alluding to some of this. So when a nuclear weapon is detonated initially at ground zero, the temperature reaches tens of millions of degrees, the pressures exceed 25 pounds per square inch, there are winds generated at hundreds of miles per hour. So clearly anywhere close to the center, it's really impossible to survive. People would really just be vaporized. As you get further out, you see, from the initial flash of the nuclear reaction, flash burns, blindness, and radiation exposure. The exothermic reaction that creates a blast will cause blunt and penetrating trauma, and barotrauma that ruptures eardrums and lungs. And then the blast coalesces into a firestorm, causing burns and suffocation. And this is a very famous image of a woman at Hiroshima who suffered flash burns, burning the pattern of her clothing into her skin. Those who are exposed to radiation may suffer acute radiation syndrome. And this is, the effect really depends on the dose and is in order of radiosensitivity of tissues in the body. So the most radiosensitive tissue in the body is the bone marrow. So you see cytopenias and resulting infection and coagulopathy. At a higher dose, you start to see effects in skin and hair. And then effects to the epithelial lumen of the GI tract, so nausea, diarrhea, dysentery, and anorexia. And at the highest doses of radiation, you start to see cerebrovascular effects with cerebral edema, seizure, and coma. And in the long term, we know that radiation exposure increases the risk of many malignancies, especially leukemia. And the leukemia literature supports the finding that these so-called secondary leukemias are much more treatment refractory. We also know from the cohort data that there's statistically significant increases in most solid malignancies. Radiation destroys the thyroid gland, both through gamma rays and also through uptake of radioactive isotopes of iodine. And we know from medical literature that radiation causes scarring and fibrosis of coronary arteries, heart valves, lung parenchyma, causes cataracts, birth defects, and of course the psychiatric effects of surviving an event like this. So this is from the Hiroshima and Nagasaki cohort, seeing the dose response effect of radiation and increased excess relative risk of solid malignancies. And here it is kind of disaggregated by solid malignancy. So again, we see lung, breast, skin, and thyroid being the highest. And all these medical consequences are happening in the context of total destruction of the remaining infrastructure on a scale much greater than we see in conventional war. So we would see some of the effects we were talking about in conventional war here, but hospitals would be destroyed, healthcare workers would be killed. So you can imagine that the ability to respond to these health effects is really essentially not there. A Russian attack targeting the US would cause 50 to 130 million deaths. And in comparison, thinking about our healthcare infrastructure, there are about 2,000 specialty burn unit beds in the United States. And here's another image from Hiroshima to kind of help visualize this total destruction. So I wanted to pause a little bit on the climate effects of nuclear weapons here because of this audience. So this is a body of literature that goes back to the 1980s and stems from some of the literature on the finding that volcanoes and forest fires can have effects on the global climate. So this is kind of based on computer modeling showing nuclear weapons being used on population centers, causing firestorms which produce atmospheric black carbon. Some certain amount of that soot is lofted into the upper troposphere and stratosphere above weather patterns and above the ability to be cleared by rain and other weather mechanisms. That soot absorbs sunlight, decreasing temperatures and precipitation, and the resulting climate changes cause crop failure, starvation, and epidemic disease. Here is a graph showing sort of what these models find in as you increase the teragrams of soot that are injected into the upper atmosphere, how the climate changes, going down in degrees Celsius here. And this is a really excellent summary slide here showing, so on the x-axis here, we have the millions of tons of soot. On the y-axis on the left here, we have percent change in precipitation, and on this side, temperature change in degrees Celsius. So starting on the left here, modeling a so-called small nuclear war, or limited nuclear war between India and Pakistan using only 100 weapons, which are only of a Hiroshima and Nagasaki type yield. The finding here was a 5 to 10% decrease in precipitation and a 1 to 2 degrees Celsius decrease in temperature. All the way on the other end of the spectrum here, a much larger nuclear conflict between the United States and Russia, causing a 40 to 45% decrease in precipitation and an 8 to 9 degree Celsius decrease in temperature, well below temperatures from the last ice age. And this is from an IPPNW paper on the so-called limited exchange between India and Pakistan, showing decrease in corn production in the US Midwest and rice production in China, which would put 1 to 2 billion people at risk of starvation, even in this limited scenario. So for this audience, I wanted to kind of pause for a moment on, sort of the response from, so this is from a group at Los Alamos, which is a lab that is involved in creating and maintaining the United States nuclear weapons stock. So they said, well, we have our own firestorm computer model. And when we ran these simulations, we found that the vast majority of the black carbon actually does not stay above weather systems. So in the limited India-Pakistan war scenario, we do not see these kinds of prolonged climate effects. And the response from the original authors noted that the limitations of that Los Alamos paper, showing a very, very low estimation of fuel loading using a suburban area of Atlanta in their model, which would have much less flammable fuel than an urban area of India or Pakistan. And they also took issue with the strong wind, the level at which the wind patterns were set, and also noted that the fire model that the Los Alamos team used was not available for other scientists to use. Okay, so the position of our organizations is that this poses an unacceptable threat to public health and life on Earth. And so I wanted to use the rest of the time to talk about what are some of the things that we can do about this. And as a bit of context here, so as we all know, our so-called global security system at this time is based on this idea of nuclear deterrence and mutually assured destruction, that if the great powers are pointing nuclear weapons at each other, then everyone will be deterred from fighting and we'll all be okay. And it's pretty obvious that there are a lot of issues with this. First of all, we know that not all actors on the world stage are nation states. There are terrorists, there are hackers who are not deterred by nuclear weapons and for whom nuclear weapons present an opportunity. We know that this logic kind of poses the question of, okay, should every country have nuclear weapons? What should the other countries do? There are a lot of issues. So while nuclear weapon states may be less likely to fight each other, we've seen that they tend to fight more proxy wars with each other and invade their non-nuclear armed neighbors more often. The idea of deterrence incentivizes unpredictable and threatening behavior in order to make your deterrence credible. And we know there have been many accidents and near misses, that our command and control is definitely not perfect. And sort of larger questions raised are, how long are we expecting the system to work? What are we willing to bet that the system works 100%? And even if it does work, is this an ethical system threatening the slaughter of millions of civilians for global security? So the organizations I work with are Physicians for Social Responsibility, the International Physicians for the Prevention of Nuclear War, which is an international network of which PSR is a part, and IPPNW won the 1985 Nobel Peace Prize. And then we also have a civil society partner coalition, the International Campaign to Abolish Nuclear Weapons, which won the Nobel Peace Prize in 2017. So I want to focus on a few different strategies for advocacy here. One is policy within the United States, so the lobbying that we do here. So the approach that we've taken here is making a nuclear weapons policy platform. So the pieces of that are renouncing the option of using nuclear weapons first, ending the sole presidential authority to launch nuclear weapons, taking nuclear weapons off hair trigger alert or launch on warning, canceling the $1.7 trillion plans to replace the entire arsenal with new weapons, and then of course, pursuing a verifiable agreement with the other nuclear weapon states to ultimately completely eliminate the nuclear arsenals. So the strategy is modeled on the nuclear freeze movement in the 1980s. Here you can see 1 million people gathered in Central Park in 1982, where that platform is taken to local and state governments to be endorsed in referenda, and then to move up to the federal level where the policy can actually be made. So our Back from the Brink platform has actually been had referenda and support passed by the state legislatures of California, Maine, New Jersey, and Oregon, and I think is about to be passed in Rhode Island. The city governments of many major US cities, Baltimore, LA, DC, Salt Lake City, San Francisco, 18 municipalities in Massachusetts, and also letters of support from more than 300 elected officials. And this picture is from the recent passage of Back from the Brink by the Boston City Council. This is City Councilor Liz Breeden here. So that's one approach, policy within the United States. So next, what you're participating in is education around the topic. So here are just some pictures from some of our activities. We had a CME module with the Mass Medical Society last fall. We have benefit concerts, and here, here I am with Setsuko Thurlow, who's a peace activist and survivor of the bombing of Hiroshima, who spoke to folks at the fundraiser there. We had Yo-Yo Ma play at one of our recent concerts. There are many tools that exist to help people understand this threat. So this is a website called Nuke Maps, where you can model one of these disasters and sort of imagine what this would look like in your community. And my colleagues also have written papers in medical journals using medical metaphors to help people understand this. So this is by my colleague Matt Bivens here, presenting the use of nuclear weapons as a kind of a never event that needs to be prevented. Like the amputation of the wrong limb or losing a wire in central line placement. And then similarly, we have an article here in circulation by Doctors Muller, Pastor, and Lehrman talking about a preventative health approach to prevent the use of nuclear weapons. Another strategy that's been employed is getting involved in the UN and international law. Biological, chemical weapons, landmines, and cluster bombs are all illegal under international law. And so our partner ICANN decided to take the same approach with nuclear weapons. So ICANN was founded in 2007. Through the early 2010s, they held a number of conferences on the humanitarian impact of nuclear weapons. This treaty on the prohibition of nuclear weapons actually passed the UN General Assembly in 2017 with 122 yes votes, unfortunately boycotted by the nuclear armed states and some of their allies. But it has nonetheless gone into force after ratification by 50 countries in 2021. And in next month, the first meeting of state parties will be in Vienna. Obviously, some limitations with this treaty, but also great strengths to this approach. And then finally, I wanted to talk about our scientific diplomacy efforts. And this is this idea that when there's no constructive dialogue going on between, for example, the Russian and US government, that doctors and scientists in the respective countries can talk to each other and reach consensus and relay our recommendations to our respective governments, media, and populations. This is an image of IPPNW co-founders Dr. Lown from Brigham and Women's and Dr. Chazov from the Soviet Union meeting with Mikhail Gorbachev. And our dialogue continues. I was fortunate to be able to go in October with Dr. Muller and meet with some of our wonderful Russian colleagues in Moscow. This was just unfortunately a few months before the war broke out. But these conversations have been ongoing during the war. Here I am with Dr. Muller and Pastor at a meeting of the Russian Academy of Sciences several weeks after the war started, where we had a chance to speak about the need to end the war and return to peaceful cooperation. And our groups have been releasing joint statements for our governments and the media, both at the kind of global level and also a joint statement between IPPNW physicians in Ukraine and Russia. And we've also, as Dr. Armand mentioned, been getting some media coverage here in the Globe and WBUR, for example. And I wanted to end with this quote by Setsuko Thurlow, the peace activist who survived Hiroshima, and invite all of you to join us in this work. It's very important. Feel free to reach out to me, reach out to any of the organizations I've mentioned. We would love to have you part of this movement. And I also want to take a moment to thank all of these folks and turn it over to the audience for questions.
Thank you so much. That was a fascinating talk. I think many of us probably learned a lot. And the way you linked it back to climate change was really eye-opening, I will say, some food for thought. We do have, one question in the chat, and this is from Sophia Wallman. And she says that she'd love to hear your perspective on the treaty on the prohibition of nuclear weapons, or the ban treaty. This first meeting is taking place on June 21st, 2022. And she said, if possible, well, she put the statement in the Q&A for people to take a look at, but your thoughts on that?
Yeah, I think the Treaty on the Prohibition of Nuclear Weapons is quite an amazing accomplishment. It's groundbreaking. I've heard Ray Atchison, one of the main organizers on that effort, speak in person. You know, it's partly a powerful statement by countries in the global South. It was supported by most countries in Latin America, Sub-Saharan Africa, the Indian or Southeast Asia, and the Pacific, saying that, you know, we all live on this planet with the nuclear weapon states, and we are not really, don't have a voice in this situation, and we want a world free of nuclear weapons. You know, the treaty recognized the disproportionate impact of these weapons on women and children and indigenous folks, which is important. You know, I think the 1968 Treaty on the Non-Proliferation of Nuclear Weapons mentions the idea of a future treaty to help the world get to complete disarmament, which I think the Treaty on the Prohibition is partly an answer to. You know, obviously there are challenges when the nuclear weapon states decide to boycott it, but I think it's a powerful event, and we should all continue to support the treaty.
Great, thank you. And then Winnie just wrote to me to ask if you can clarify what these organizations do, and that you don't have to be a physician to join, and that one of these is actually led by a nurse practitioner. Is that correct?
So certainly you don't have to be a physician to join any of these organizations. Anyone is welcome. I don't know the answer to that second piece, but yes, we have I'm involved with the Boston chapter of the Greater Boston chapter of PSR. Oh, and it looks like my colleague Ira's in there. Yeah. Okay.
Let's see, what time is it? Okay. The one question in the chat says, the Russians have used nuclear power plants in the Ukraine as potential targets and as a place to shelter troops, knowing that they won't be attacked. How are nuclear power plants in the United States structured to defend against terrorist attacks?
I don't know a lot about the answer to that question. I will say that there are some anti-nuclear power activists who have done actions demonstrating the lax security at US nuclear power plants, the ability to kind of walk in and things like that. So, but I don't know the answer to that question specifically.
Okay, great. That's a pretty tough question to answer.
Yeah.
Sophia also wanted to know if you could discuss the ABOM Casualty Commission, if you're familiar with that.
Yeah, so so the data that I was showing were largely from the data from Hiroshima and Nagasaki, largely from cohort studies that have been published later on. So what Sophia's alluding to here is that shortly after the war, American doctors came in, and there was a lot of research on survivors that was not, that the community did not really like how it was being done, because it was, you know, I think a lot of people felt that they were being treated as guinea pigs, and that the direction that research took, you know, over the decades, there was advocacy around that, and turning over the cohort data and the research to folks who are in the communities and invest in the communities. That's I think what Sophia's alluding to there.
Okay, great. Which is very interesting and pretty profound that American researchers were going in and doing that. We continue to have these issues with research ethics, don't we? Yeah. So I guess it's your colleague Ira put a website for Back from the Brink campaign into the chat for people. And I also wanted to mention as we close that someone did actually put something in the chat to say, thank you for making a scary topic end on a hopeful note. So I'm going to turn it over to Patrice or to Winnie to wrap it up. And thanks again.
Thank you so much, Dr. Hodgkin, and to the audience. And we'll sign off now. See you next month.